Hello and welcome to our latest Gastro Learning live event. I'm George Webster, and it's an enormous pleasure to welcome our friend and colleague, Mehta, who is the head of nutrition at the Barts Health and the Royal London Hospital, previously with us at University College Hospital, and a source of enormous regret that he has taken his talents elsewhere. Great to have you with us, Sham, and the focus for the next 30 minutes is going to be on an area that impacts almost all areas of medicine, which is enteral feeding. It's almost whatever area of certainly gastroenterology one works in. There are the constant questions of, can we have a PEG, or can we have a PEG-J, or we need a nasojejunal tube for this patient? And I think it's going to be really useful to just have some discussion and some expert tips about, across the board with this topic, some technical tips and tricks, which we're going to really value, but also some broader views as to the way we should be approaching these patients, and in a slightly artificial way. I think if you're happy for us to do it like this, it might be useful just to sort of divide up the actual procedures, even though the issues around case selection may be quite similar. So I think it'd be useful to start with PEGs, percutaneous endoscopic gastrostomies. And really to get your views at the outset about patient selection, because it's an area that can be a subject of debate and even conflict as to which patient should be selected for PEG. So I wonder if you might, firstly, great to have you with us, and give us some comments on the do's and don'ts, shall we say, of patient selection.
Yeah, absolutely. And thanks for inviting me, George. I mean, I absolutely echo your comments about enteral nutrition and artificial nutritional support in general. I mean, I think that as a nutrition team, we have a wide, this area of responsibility, really, in terms of improving and optimizing outcomes for patients in all areas of the hospital with chronic, medical conditions, but also importantly in that operative setting as well. And I think a lot of that really relates not only just to kind of the technical aspects of tube delivery and insertion and management, but also the patient selection and actually you're running your entire enteral and parenteral service. And I think if you focus down onto PEG tubes, the way that I think about this is that there have been some amazing advances in therapeutic endoscopy over the last 10 or 15 years. I mean, not least in your own sphere of practice, George, and sort of PB endoscopy. If you think of all of the amazing techniques that you guys now use, with those slightly increased risks to patients, amongst all of those things that we do in the endoscopy unit, still PEG tube placement is associated with amongst the highest morbidity and mortality. And we're talking, 27% mortality at 30 days, up to 50% at 12 months. And largely, this is related, in my mind, not so much to the technical aspect of insertion, but patient selection. And I guess if I've got 3 tips for PEGs in general, it is selection, selection, selection. Because in general, these are patients who are, as we all know, a bit older, more likely to be polymorbid, coming through a catabolic illness, sepsis, or a perioperative long admission, and these are the patients who are much more likely to do badly. I think we should also, as endoscopists, be not afraid to voice our opinion in terms of mitigating against those risks. So if we are not happy that sepsis has been cleared, if we're not happy that respiratory function has been optimized, that coagulopathies have been corrected, electrolytes have been corrected, it is absolutely the right thing to say, these things need to be done. We're going to delay for a few days until these are optimized. So I think selection is absolutely key, and mitigating against those patient-related factors is crucial.
Yeah, okay, that's great. And it's fair to say that a PEG placement is almost never an emergency. There's almost no scenario that's the case. And can I ask further about patients, about procedure planning? Two areas really. One is anesthetic support. Anesthesia support and endoscopy is a limited resource. But I'd value your comments on that. And also, we've all had the scenario of a patient where there is unusual anatomy, and that either precludes the PEG being placed or even causes complications. Tell us about pre-procedure imaging and the scenarios in which you would say, look, we really need to have an ultrasound or a CT scan before we can proceed here.
Yeah, of course. I'll start with imaging first. I mean, if we're talking about the classic indication, for example, a patient with a neurological problem, perhaps a stroke, who's had no previous abdominal morbidity or operation, I would not routinely be asking for abdominal imaging there. Okay. I like very much going up to seeing patients on the ward who are going to be on my list, because I think, if I can go up there, eyeball them, examine their abdomen, and I'm happy with that, I would not routinely be asking for abdominal imaging. I think, and I think the patients in whom you might want to consider that are patients with, multiple previous resections, more than one operation, scars, and taking a bit of a surgical approach. Surgeons will often be guided by timing of surgery in terms of just examining the abdomen, particularly in patients who have an intracutaneous fistula, for example. And I think we can do a similar thing with as gastroenterologists, examining the belly, and having a feel for it, and understanding whether in that patient do we want to perform any imaging or not. Personally, I would have a very low threshold. If at all you're worried, if they've already had some imaging, they've got an enlarged liver, or actually perhaps just take the opportunity to review that imaging with your radiologist, I would have a very low threshold for doing that.
Okay.
The anesthetic support, I think that's really difficult, because I think, there is very little capacity for anesthetic support, in the UK currently, and I suspect elsewhere in the world. And many patients, actually, although it's not the most pleasant procedure, it is entirely tolerable. And if you've got a good team around you and you're familiar with your kit and your team, this is not a particularly prolonged procedure if it all goes well. And so I think, again, routinely, my preference would be not for anesthetic support. But you've got to be really aware of the kinds of patients you're performing these procedures on in your own hospital. Okay. If at UCH, you're linked to a large neurology hospital, lots of patients with advanced complex neurological disorders, motor neurone disease, and so forth. There's bulbar pathology, a risk of airway compromise. In those patients, I think it is worthwhile considering setting up your service with perhaps regular anesthetic support to achieve the right outcomes. But okay. I don't tend to talk for it.
That's really helpful. And a couple of words on, clearly the list is endless, but are there any particular contraindications that you say, look, we're not going to go there? The patient with portal hypertension, or esophageal stricturing, for an example, or even head and neck cancers, and any scenarios in which you say, look, one can't consider in this situation a patient for a PEG?
Yeah, I mean, I think there are some absolute contraindications, which I would not consider placing a PEG, and those are sort of obvious things that I think we would all consider, which include, intestinal obstruction. This is small bowel obstruction, peritonitis, sepsis, and so forth. I think it's worth talking about the relative contraindications a bit more, because there's a bit more granularity here. I think if we focus on head and neck cancers, there is good data in literature that suggests that this is associated with seeding of tumor cells from the primary site to the gastric site. And that's in the order of about 0.5%. Now, that doesn't sound a huge risk, but if patients are undergoing treatment with curative intent and then get distant disease because of a PEG tube, I think that's a pretty disastrous outcome. We know that risk is reduced using the push method of PEG tubes, so using gastropexies, because you're not pulling through a flange in a PEG past the head and neck and the nasopharynx. And actually, there's now guidance that suggests that actually, if that is available in your trust in your hospital, then that is the preferred mode of treatment. It isn't available everywhere, but we now have guidance that suggests that for this specific cohort of patients, the push method is preferred.
Okay, yeah, it's interesting that, isn't it? I mean, anecdotally, we've seen, I think lower levels of success with rigs, particularly if there's any problem passing a nasogastric tube down in order to insufflate the stomach. Some of our radiologists who were very good, have a challenge with rigs. But certainly, if one isn't passing the oropharynx in a patient with a large head and neck tumor, then clearly there is virtually zero risk of seeding in that setting. Okay, Sham, that's very useful. Let's move on to PEG selection. Do you have a go-to size PEG? Do you say, every patient for feeding, it's a 15 French PEG or 12, or do you tailor that consideration, or do you just have a standard default?
So some of this is related to training and dogma and what you're used to and what you've got available in your hospital. My go-to system tends to be the Frecker tube, which I think most people will be familiar with, which is the pull-through tube with the disc as the bumper, as the anchoring method. And I would generally place nothing less than a 15 French tube. I think there are very few. One of the major problems with PEG tubes in terms of complications really does relate to blockage and leakage of the tube. And I think, going down from a 15 to a 9 French really does cause significant problems with blockage of the tube, particularly if it's being used for feeds, but also for medications. So I think we see that with jejunal extensions, which are generally 9 French. So I would really try to avoid placing a smaller gauge tube. And then if you think and extrapolate that to, for example, venting pegs, where you need a much bigger caliber of tube, of course, we don't have tubes that are specifically designed for venting. The tubes are still designed for feeding. And at the end of the venting peg tube, the Luer lock narrows down the caliber. Yeah. And so, although these tubes, we tend to offer these to patients for palliation of their symptoms, we know they're not perfect, and they come with problems when patients are discharged. And I think certainly, with industry, that is an area, along with surgical jejunal tubes, we need a good venting tube that's designed for that specific purpose.
Yeah, great point. Let's say a few words about some of the technical issues around PEG placement. And I suppose a couple of related points. The distance between the internal intragastric button and the external connector. Do you have a rule of thumb about a distance that worries you? How tight do you secure the PEG initially, and are you influenced by how much adiposity there is? And finally, on that, do you go back down with the gastroscope having inserted the peg?
Okay, so I'll answer that last bit first. The answer is no. That's very
same here. Yeah.
There's data now, that's controlled data, that suggests that a second look endoscopy, if you're not worried about the bumper distance, which we'll get to in a moment, has no added value to changing management. So I think that's very clear, and I don't routinely do that. Okay. In terms of bumper distance, that is, I think, much more important. And I think it is absolutely crucial to actively measure the bumper, document it, because for a really important reason. And generally, when patients have a PEG tube placed, in many hospitals, they'll be admitted overnight or they'll be existing inpatients, so they go back up to the ward. And that management of the PEG tube for the first 12, 24, 48 hours is key, because you often get changeover of ward staff. There might be some discomfort at the PEG tube site, which is very, very often. And the temptation of ward staff is to loosen that external bolster slightly in an attempt to relieve some discomfort or to clean around the PEG site. That, in the first 12, 24 hours, can lead to the stomach falling away from the anterior abdominal wall. In the absence of a mature tract, you then get spillage of gastric contents, peritoneal irritation, and patients can be quite unwell, requiring IV antibiotics. And from a complication that is really entirely avoidable. So,
I would say that more than unwell. I've been involved in PEGs for 20 years, and the only fatality I've seen directly related to a PEG was exactly that scenario of back to the care home, and somebody diligently looking to clean around the PEG at 24 hours and releasing the clasp, cleaning around and reconnecting the clasp at 14 centimeters when it was secured at 3 centimeters, and the patient having fatal peritonitis. So, I think that's a really, really important point that, we need to be careful about. And on complications, we consent the patient for infection, for free perforation, for bleeding. I don't know if you want to say any particular comments about that. We sometimes see bleeding that in fact is external and probably relates to a little arteriole at the skin, which is a frustration rather than usually clinically important. Do you want to say a bit about early complications, and then maybe, while we're on the topic, about buried bumper and how we avoid that and how we manage that?
Yeah, absolutely. I mean, I don't see bleeding very often, if I'm honest. As a clinic, we always consent for that. Actually, as that causing a clinically relevant complication, that to my mind is actually quite uncommon. I think the things that are most important for patients in terms of their quality of life as a chronic problem absolutely are infection and leakage. Leakage is really common. Okay, I mean, it's reported in up to 75% of patients. Some of my colleagues don't consider this a complication. They consider this as the natural history of having a PEG tube. And the important...
Sham, this is external, this is leakage around the tube.
This is, in the chronic setting, leakage of gastric contents around the stoma site of a PEG tube.
Yeah.
It causes a degree of local irritation, perhaps as a harbinger of chronic infection, usually fungal infection. This is best managed conservatively. Best managed using barrier creams with zinc oxide. That's the key. The temptation as an endoscopist and a gastroenterologist often is to upsize tubes. That often, all that tends to do is to kick the can down the road. You might get a little bit of a resolution for a few months, but what tends to happen is that the stoma tract just simply dilates over the bigger tube, and you're left in the same scenario. So I would tend to avoid doing that despite the temptation. And really, this is where a good nurse specialist who, you know, knows their creams and can manage expectations with patients comes into play. But that's what I'd say about that.
Yeah, and any, you know, ever a role for getting the surgeons along and putting a little stitch to tighten the stoma, or is that equally hopeless?
So there's a difference between a leakage and a chronic gastrocutaneous fistula with cellulitis and skin excoriation. Those are two very different scenarios. I've dealt with both. In fact, I've dealt with quite significant problems relating to fistula. And in those situations, yes, there is a role for endoscopic suturing, but it really does depend on the patient, and it isn't always effective for all patients.
Yeah. Okay, that's very useful. Let's move on to well, sort of terminology, but also some practicalities, and that is PEG, PEG-J, surgical jejunostomy tubes. You know, we a while ago were asked to change a PEG, and it wasn't a PEG; it was a surgically placed jejunostomy tube. And of course, you go into the stomach, and there's no tube to be seen. You know, it's an area of that is hounded by terminology, but also practicalities, because inserting a PEG-J is a very different undertaking to inserting a PEG. Some comments about maybe sort of wrong requests for PEG-Js. You know, many non-gastroenterologists don't realize that it's a hell of a bigger intervention to be requesting a PEG-J than a PEG. So some comments about disease indications for PEG-Js versus PEGs. And then, as we all know, these can be, the PEG's straightforward, 15 French PEG, but then the jejunal extension can be a really challenging thing to pass. So a few comments, if you would.
I think when we're receiving these referrals, I think there are some very hard, reasonable indications. If you've got a patient with a gastric outlet obstruction or a physical issue, you know, complications of pancreatitis, benign disease, you know, those are all reasonable indications that I think we can all agree with. I think if you've got patients with functional bowel problems, perhaps patients with gastroparesis, those are, I think, harder to reconcile. These patients often have things like bloating and pain, suggesting the visceral hypersensitivity. I think the question has to be asked about whether a jejunal extension will really help those patients. The other common scenario, I would say, is aspiration risk. You know, a patient who's got an aspiration from PEG feeding, you're asked to place a jejunal extension. There is good data that suggests that does indeed reduce aspiration risk, but does not improve other important clinical outcomes, length of stay, ITU admission, and importantly, all-cause mortality. So it's important that to do that, we make that very clear to patients and their relatives.
Okay, now that's very helpful. And, you know, sometimes what is wanted is a post-pyloric tube rather than a true jejunal extension tube. But if the latter is what's needed, then it's not easy, is it? I mean, I have to say that over the years, we have followed an approach of, you know, inserting the 15 French PEG and then passing the 8 or 9 French jejunal extension tube into the stomach, and then carrying that tube down on the end of the stent grabbers, and gently inserting maybe round into the jejunum if we're lucky. And then, of course, we slowly withdraw the endoscope, and then we release the snare and we come back. And then before you know it, everything has come back into the, you know, the jejunal tube is now curled back in the stomach again. Do you have some tricks and tips for how to successfully pass a jejunal extension tube through a peg without that level of frustration?
Yeah, I mean, we've all been there, haven't we? It is incredibly frustrating, and you've got to maintain patience. There's a really nice technique which I've started using, which has been described in 2017, which is where you can actually place your scope through a snare. And so, if I very briefly describe this, if you can imagine a patient with a peg tube, you pass a snare through the peg into the stomach, you open out that snare, you drive your gastroscope through that open snare into the jejunum, pass a wire through your scope into the jejunum, use screening, ensure you're in the right position. You exchange, you remove your gastroscope, keeping your wire in the small bowel, and you withdraw the gastroscope through the snare. You can then grab your wire by your snare, so close your snare around that wire, pull it out of the patient, and then this is the important bit, pull out the wire that's in your gastroscope out of the patient, and then you're then left with a wire through the peg into the jejunum directly, which you can then use as a guide to railroad your jejunal extension. And you can do that under direct vision and using screening. And that overcomes that really frustrating aspect of the extension flipping back when you withdraw the scope. So that's a really nice technique that I tend to use. And the other thing I would say about peg Js is that they also do have the added risk of a buried bumper, as do pegs.
Okay, I want to get onto buried bumper, but I'm afraid, Sham, if you think that all your work is done after this evening, it's not, because we're going to get you to do a short video, not today, but a short video demonstrating that technique that we'll put on the Gastro Learning site, because I think that it's beautifully described, but it will actually be even more useful to have a brief video with you demonstrating that. So that will be a really important thing to do. Sorry, we want to talk about buried bumpers, because in some ways, buried bumper syndrome is an absolute heart sink, isn't it? The patient has been doing fine often with their peg. It's time to change the peg, or there's a problem with the peg. One thinks it's going to be a straightforward 10-minute job to change the peg, and there's a disaster because there's a buried bumper. Tell us a bit about the risk factors for buried bumper, how to avoid it, and then there is lots of ad hoc approaches to dealing with it, but maybe a few words about how to resolve a buried bumper as well.
I feel quite strongly about this, because this is the most feared complication of a peg. The interventions to solve this are not without significant risk to the patient, and this is entirely avoidable by really simple techniques. Advancement and rotation every week. I almost think that this should be classed as an NHS never event, if I'm honest. And I think it's incumbent upon us, whenever we see a patient with a peg tube, is just simply asking the question, has it been advanced and rotated in the last week? And if it hasn't, then to do so. But if you're coming across it as an endoscopist, broadly speaking, there are mechanical techniques and there are diathermy techniques. And there's, you can use a snare, placed around the sort of cut external portion of the peg and providing traction for internal pulling into the stomach. You can do the same with a balloon, so a through the scope balloon inflated within the peg tract, providing a radial force as your anchor and then pulling in, and then perhaps using needle knife if you need to dissect down the gastromucosa, probably in combination with one of those mechanical techniques. I think if you come across this, the important thing to as a learning point is simply maintain the tract. Just place a jejunal extension through the peg, maintain that tract, just leave it in the stomach, and then we can make some decisions and have your multidisciplinary meetings thereafter.
Okay, very, very good advice. Just wanted to take you back to the necessity to advance and rotate. do you want to put a caveat on that in terms of timing after initial PEG placement? Do you not do, presumably you don't do that within the first 2 weeks, or what would your time frame be?
Exactly that. So the guidance is 10 to 14 days. I think 14 days is my preference. It's very unlikely you're going to get a buried bumper in the first 2 weeks, is my feeling. I've not come across that. There are reports, but I've not come across that. So I think 2 weeks is a safe timeline. I guess the other thing to say as well is, in terms of decision making, is whether there's ever any situation where you can simply leave a buried bumper in situ. Because of course, some of these patients may well have a limited life expectancy. If surgical removal and anesthetic risk is high, there is an argument for simply leaving a PEG in place, placing a PEG at a different site, or a jejunal extension through. There are some small case series that have demonstrated that complications as a median follow-up of 18 months are 0. Obviously, in a select group of patients, but that's an option that should be included in discussions, I think, when you're planning the right treatment for a buried bumper.
Okay, that's very helpful. We've had some great questions coming in. In fact, we're really out of time, but I just wanted a good question about presumably with regards to the PEG-J question. Oh no, there's a question on do you place a nasogastric tube first as a trial? And I suppose that's a question largely about the timing of PEG placement. Do you have a rule of thumb, the patients who, for example, comes in with let's say a neurological event in which it's felt that their swallowing is unlikely to make a recovery? Do you have a rule of thumb as to how long you maintain nasogastric feeding before reverting to a PEG?
Yeah, I mean, I think, in patients with neurological problems and strokes, it's usually very straightforward, isn't it? You tend to get those referrals 2-3 weeks down the line. Those are usually clear cut. I think the harder ones are the patients who are perhaps as outpatients, who are not doing well, and they need a sort of medium to longer term feeding. And for those patients who've never had nasogastric feeding before, or any enteral nutrition, I would advocate for NG feeding before placing a PEG. Not only because you don't always know how well they tolerate different feeds, and it's important to know that before you're doing an intervention that is not without risk. Okay,
that's really excellent. Amazingly, we have run out of time. We could talk for another hour about this topic, because I think there are so many aspects to it. We will corner you with regards to your nice little tip about jejunal tube placement and PEG-J. But for now, Sham, thanks ever so much for joining us, and thank you for everybody for listening in. You can watch this anytime you like on the Gastro Learning site. And as I say, there will be more tricks and tips with respect to this and many other topics. So thanks very much for joining us. Have a good evening.
Thanks very much.